Hello everyone, welcome back to the cardiovascular series of AMC Part 1. In this video, we'll dive into 5 high-yield topics that AMC loves to test you. Those are peripheral artery diseases, intermittent claudication, acute pericarditis, myocarditis, and pulmonary hypertension. So let's get started with peripheral vascular diseases. So a brief overview of this topic is basically it is caused by atherosclerosis of the arteries and it most commonly affects the lower limbs. And the AMC keyword that you need to see in question stem is progressive exertional leg pain, and that is relieved by rest. So the few features are claudication, rest pain, and then we have this diagnostic thing, that is ankle brachial index. It is the investigation of choice and the initial investigation that you have to do. So these are the criteria. So if it is more than 1.4, 0.9 to 1.4, less than 0.9 or less than 0.8. So if it is more than 1.4, then you have to obtain toe brachial index. Then if it is more than or equal to 0.9 to 1.4, then it is normal. If it is less than 0.9, then it is you have to refer it for PAD diagnosis, and if it is less than 0.8, then it is a contraindication for compression stockings. So you have to make sure that you remember and see it in the question stem that what value is given. Then we have, so if the revascularization process is indicated, then what are the investigations we have to do? So initial investigation, if revascularization is indicated, that is MRA and CT angio. So these two we are doing only when intervention is planned, right? And if we want to locate or localize the basically the clot wherever it is happening, for that we'll have to use duplex ultrasound. There are two situations where we are using duplex ultrasound: if the person has contraindications to angio, or the person is having problem with the contrast, or the person is having renal failure. But the gold standard is DSA, that is digital subtraction angiography. Now for the diagnosis, there is a Burgers test that the person can do, and you can diagnose it on the basis of that also. And then for the management, smoking cessation is the number one thing that you have to do, that is the lifestyle management. If medications are required, then aspirin or statins you can use, or cilostazol, that is for claudication and revascularization if there is a critical limb ischemia. Next topic is intermittent claudication. This is a classic symptom of peripheral artery disease, and I want you to think it like there is an angina of the leg. So basically there would be muscle pain on exertion, and it is relieved by rest. So there are different locations to it, but the most common locations are femoral or popliteal artery, that is calf, or iliac artery, that is buttocks or thigh. Now for the management, as you can see that I have marked all the lifestyle interventions or medical therapy. It overlaps with the peripheral artery disease. Now for important thing is chronic limb ischemia, then we have to do revascularization. If it is a small intermittent claudication, then thromboendarterectomy we can do. If it is big, then bypass, grafting we can use. And if the lesion is gangrenous, then amputation is the only choice that we have. Next is acute limb ischemia. So for the diagnosis, the initial diagnosis intervention is arterial or venous Doppler ultrasound, and for the confirmation we have to do CT angio. And the treatment protocol, it starts with systemic anticoagulants, that is IV heparin. Along with that we'll have to give fluids and thrombolytics. Now when we are thinking about revascularization, the first thing we have to see is if the limb is viable or non-viable. If the limb is non-viable, then amputation is the only choice that we have. And if the limb has viability in it, then we have to see if it is non-threatening injury or threatening injury. So if it is non-threatening, then urgent angiography you can do and revascularization process you can start. And if it is a threatening injury, then emergent revascularization we have to do, and the time frame for it is within 6 hours you have to complete it. Next topic is acute pericarditis. It is the inflammation of pericardium, and AMC asks about it for sure. There is a clinical triad. First is sharp pleuritic chest pain, and the person get relieved when he is sitting forward. The second is pericardial frictional rub, and the third one is diffuse ST elevation with PR depression. So this ECG finding is very much important. You have to see what this ECG looks like and just try to memorize it. Then we can do transthoracic echo. If it is inconclusive, then we'll have to do CT or MRI. This is for the investigation part. Then there could be multiple causes for it. It could be MI, it could be the Dressler syndrome, or it could be uremia or SLE. Now for the treatment, we'll have to start with NSAIDs. With colchicine we can give but NSAID specifically indomethacin, and the person is having high risk for GI toxicity, then PPIs we can use. And if this whole thing is contraindicated in this patient or it is ineffective, then steroids we'll have to switch to, that is prednisolone. Then the next topic is myocarditis. It is basically the inflammation of the heart muscle itself. Now there could be multiple reasons like Coxsackie B virus or adenovirus. It can also be autoimmune or because of some drugs or idiopathic. Now the symptoms can range from mild chest discomfort to acute heart failure or sudden death. Now for the investigation, ECG we have to do. In that we'll see sinus tachycardia and non-specific ST changes. Cardiac markers are very much important, that it would be elevated in this, like troponin, and inflammatory markers would also be elevated like CRP and ESR. For the confirmation we have to do echocardiograph, and MRI we have to do cardiac MRI, and with the biopsy we'll be able to see myocardial necrosis. For the treatment, NSAIDs and colchicine we have to use, and steroids are also effective. Now the next topic is pulmonary hypertension or cor pulmonale. So basically it is mean pulmonary arterial pressure would be more than 25 mmHg at rest. This is the diagnosis. There could be multiple reasons for it, but the important thing is you have to remember that the problem is in lungs itself. For the investigation, we have to do transthoracic echocardiography with or without pulmonary function test, and this condition, it is a contraindication to pregnancy. Next is chest x-ray we can do, BNP levels would be elevated, but for the gold standard it is right cardiac catheterization using a Schwann-Ganz catheter, and we'll measure the pressure. So pre-capillary pressure and post-capillary pressure, we have to see these pressure markers. Now signs could be right heart failure, pre-sternal hive, or loud second heart sound. These are the features. For the management, first is calcium channel blockers, the second one is combination therapy with sildenafil or endothelin receptor antagonist, that is bosentan. And if the patient is at high risk for any sort of intervention, then prostacyclins we have to use, that is epoprostenol. Now we have to avoid pregnancy if the patient is already having pulmonary hypertension, but if the patient is being diagnosed with pulmonary hypertension after knowing that she was pregnant, then mode of delivery would be C-section. The AMC can ask it a question like this, that the patient now has pulmonary hypertension and she was already pregnant, so then the mode of delivery would be C-section. This is how you can tackle the question. That's it for this video. If this video helped you clarify these important topics, please make sure that you hit the like button or subscribe to the channel. And next video I'm thinking of making a dedicated video for heart murmurs, so that would be beneficial. Until next time, keep revising smart and stay confident for the exam. Thank you.